Okay, hello everyone. Welcome to the sixth session of the Teach, Lunch, and Learn webinar series. Today's topic is tobacco cessation in oncology with Kristie Morydz from CancerCare, Manitoba. So if you are interested in obtaining a letter of completion for today's Lunch and Learn webinar, you would have had to have completed the registration form and pre-learning assessment. Sign in and view the live webinar session using your first and last name. If you have signed into the webinar as a group, please email me by the end of today with a list of the group members as well as email addresses. My email address is on the side of the screen. As well, if you have joined us via teleconference only and not signed on to the web, please also send me an email by end of today. So it's Tanya Teach, Teach at camh.ca. And then following the webinar, we will send out the post-learning assessment too for everyone. These webinars are being live tweeted on Twitter. Follow CAMH Nicotine Dependent Service on Twitter at PS Quit Smoking. To follow the live tweets or to post questions, please use #TeachWebinar. Today's presenter, as I mentioned, is Kristie Morydz. She's a nurse practitioner at CancerCare, Manitoba. She's been there since 2001, previously working on the blood and bone marrow transplant ward at the Health Sciences Center. Kristie is an active member of the Thoracic Disease Site Group, seeing the clients throughout their journey with thoracic malignancies, as well as seeing clients with GI malignancies. She has helped to develop the tobacco cessation program at CancerCare Manitoba and assesses and assists clients and their families with cessation. There are no disclosures to report. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Contents of slides are primarily based on evidence-based guidelines with the following three sources. The development and delivery of the TEACH curriculum is not influenced or funded in any part by the tobacco industry. TEACH has not received funding from the tobacco industry. The development of the TEACH curriculum has not been influenced by pharmaceutical industry, and information presented on pharmacotherapy refers to generic products only, and recommendations are based on existing research, including the Canada and US guidelines. These materials, as well as the verbal presentation and any discussions, set out only general principles and approaches to assessment and treatment pertaining to tobacco cessation interventions, but do not constitute clinical or other advice as to any particular situations and do not replace the need for individualized clinical assessment and treatment plans by healthcare professionals. Okay, so I'm going to pass it over to Kristie to take over with the presentation, and I will join you again at the end of the webinar. Thank you everyone for signing in today.
Okay, how was that? Good. Good. Okay. All right, so we'll move on. Okay, so for this talk today, I'll just give you a bit of an introduction into the smoking cessation in general and the oncology population. We'll look at the oncology client. We'll look at our CancerCare Manitoba previous practice as well as our current practice now. Look at the opportunity for a teachable moment for both the patient as well as, or client as well as for their family members, and look at cessation and the benefit for our oncology patients, and then a little bit more about our program here. So Manitoba has made great strides in limiting tobacco exposure through policies and changes. So looking at no smoking in vehicles, no smoking in public places, and we know that has made a difference in reducing the number of smokers, but it also has, or people that use tobacco, it also has, we're hearing that reported from our clients when they come in and they say, well, actually, I smoke less than I did, say, 5 years ago because I just can't smoke out in where I used to, or when I go out to eat and things like that. So it has made a difference. We know by the numbers, but we know from patient or client reporting that it has. Despite this, we still have a lot of people in Manitoba that use tobacco, and Manitoba also has one of the highest youth tobacco rates. Because I work in thoracic and it has such a tight tie with the use of tobacco, it just shows some incidence of lung cancer in Canada. And then this is just to look at daily tobacco use for clients who are 18 years and older. So Manitoba, we sort of fit right in the center when we're looking at numbers for the Canadian population. Again, a tight tie with lung cancer, and really if we could, because it has such a tight tie, if people weren't smoking and using tobacco, we can really bring our lung cancer numbers down. Again, there's other tobacco-related disease. Obviously, we're here looking at cancer and oncology, and you can see that's right at the top when we're talking about the use of tobacco. But certainly, we know that there's many other diseases that are brought on or impacted by the use of tobacco. Again, looking at the causes of cancer in the developed countries, tobacco right at the top. So when we're looking at our oncology clients, many people would think, well, you know, they've already had sort of the scare from their tests being done and their workup that many of them would have quit on their own. But we know that up to half of individuals who use tobacco will continue to smoke after a cancer diagnosis. So this is going through the scare, there might be something there, all the diagnostic tests, even after the biopsies or the surgeries that might be done, these patients continue to smoke despite this. And we know that our oncology patients have unique benefits from cessation. We have found that an individualized approach is important for our patients. Our patients are often very complex with their medical history as well as their cancer treatment, and so we treat each patient individual. We don't use groups right now. Right now we're seeing patients one-on-one. And we implemented the tobacco cessation program to CancerCare to address the needs of these patients. Our previous practice is kind of disjointed. So we previously, overall patients were advised not to smoke for the most part, but that wasn't from every provider. We weren't consistently asking about patient smoking status, and it wasn't being consistently documented. So, you know, years ago, we just don't have those kinds of numbers to know of the patients that walk through our doors, how many of them are smokers. Did we even ask? And if we didn't ask, obviously the ones that weren't asked, they weren't advised to quit. For the patients that were advised to quit, we didn't have play a direct role in that. So we advised them that they should quit and then ask them to go back to their family physician or general practitioner or for assistance. We A lot of our patients said, I'm not doing that. I'm going to be here for the next 3 months getting treatment. The last thing I want is another uh, provider visit. Why should I go there if I'm already seeing you? So we've had lots of excuses. Some of the excuses were because patients weren't ready, but other excuses were legitimate. We were keeping them here tied up for treatments, but yet we weren't taking that next step to help them with cessation. So, unfortunately, but fortunately, an oncology or cancer diagnosis is a teachable moment for our oncology patients. So, cancer screening and diagnosis sort of gets people's attention. It's not only for the client, it's also for their family members. So, this is a time where the family members are wanting to do something, they're motivated by their loved one's diagnosis, and it often puts them in a space where they're ready to make a change. And after a cancer diagnosis, more than half of individuals who use tobacco products report making a quit attempt or an interest in looking at a cessation program. So we have these people's attention here, and many of them report they're ready to make a change. So with oncology patients, of course, we know for all of our patients, a client in general, there's benefit to quitting smoking. No matter where they are in their life spectrum, there's benefits to different aspects. For oncology patients, we have specific benefits that we see based on their treatments. Radiation itself, if you're using tobacco products during radiation, it can actually reduce its effectiveness by radiation works well with nice oxygenated tissue, and smoking sort of changes that. The smoking while on radiation treatment has been shown to decrease the response to treatment as well as survival rates. We do use this to motivate patients to, say this is the time, and if they say, why bother now? I have a diagnosis of cancer. We tell them about the facts and what we know from some trials, and it does make people more motivated. It also helps us when we're talking to the oncologists. Some of the oncologists aren't, or other providers at CancerCare, aren't convinced that patients should be quitting smoking at this time. Sometimes they don't want to bother them because they already have a diagnosis or don't know that there is a benefit. So we use this information to help motivate them as well, because they want to have good response and outcomes for their patients as well. We know that tobacco products affects the pharmacokinetics of drugs. We know the circulating smoke changes the metabolism of some drugs. We know this is common with some antidepressants. We know this with caffeine. For anti-cancer drugs, we know that certain drugs have been shown to change its metabolism in the presence of smoke. And one of them is irinotecan, and this is a chemotherapy drug that we use. We use it sometimes for lung cancer patients. We use it in GI malignancies. And the smoking with it can reduce its efficacy, as well as erlotinib. And erlotinib is a drug that we use for lung cancer patients. And they've looked at this drug with patients who smoke, and they have found that the circulating erlotinib could be as much as half of that in a non-smoker. So it brings to think of things, are these patients being underdosed? And certain centers and certain trials have looked at increasing the dose of the erlotinib for patients who smoke. So this is to try and bring them up to the level where non-smokers are, to the circulating drug in their body, to see if they can get benefit from it. This can be an issue because erlotinib can be quite a pricey drug, depending on the province, how your cost coverage, but ours is covered through the government. And we're asking, right now we're dosing everyone the same, but in the future, should it be shown to be beneficial to increase the dose or double the dose of the erlotinib for smoking patients, that could bring up issues when we're talking about funding and costs. So of course, surgery, we know that there's a greater risk of post-surgical wound problems in those who use tobacco products compared to not. Pulmonary complications are less frequent in those who have quit preoperatively. I know speaking to some physicians, when patients are extubated, they like to have a nice smooth extubation. They feel good about that, and they know that there's a difference between the smokers and the non-smokers. So performance status, this is another thing that we look at a lot in oncology. We're looking at a lot more over the years now when we're doing clinical trials and looking at performance status. So we found that performance status is better in those who've quit after a cancer diagnosis. And so how this trial is a bit unique is it looked at lung cancer patients and it looked over the spectrum of disease. And what they found is there is no point that smoking cessation is not beneficial for a patient. So for those people that say, why not let them, they don't have long to go, or those kinds of things, this sort of speaks to that, because for people, lung cancer patients who have quit after diagnosis, they were seen to have better performance status 6 and 12 months later. But this is seen regardless of the disease stage and type, regardless of the patient's characteristics and the treatment types. So regardless of where they are in their disease, if they're early diagnosed lung cancer or a stage 4 lung cancer patient, and despite the treatment that we give, smoking cessation improves of performance status. Of course, we know there's a survivor benefit as well. Cancer survivors are at risk of recurrence. They're also at risk of developing a second primary cancer. So their second primary cancer, if their first cancer may be from their behavior, some behaviors that could be modified, such as tobacco use, such as alcohol. If we don't make changes in the behaviors or the addictions, then of course they're at risk again for developing a second primary cancer that may be related to either tobacco or alcohol use or any other substance. So we really need to look at smoking cessation for these patients, even into when we're looking at survivorship, and after they've been through their treatment, if they weren't ready to address it then, when we're looking at survivorship, we should be addressing it. Studies show an increase in distant metastases and tumor recurrence in those who continue to use tobacco products. So in January 2012, a tobacco cessation program was established at CancerCare, Manitoba. So as I've said before, it's a personalized program. It's available to all our CancerCare Manitoba clients, as well as their family members, and then we sort of have a loose definition of family members, as well as CancerCare Manitoba staff and their family members. So with the family members, the family members of the clients are invited to participate in the program. They offer support to the client, as well as to the family. And I say that to the family because often the family are frustrated with, what can I do to help my loved one? What can I do to be there for them? And often there's not a whole lot that they can do. But with if they are using tobacco and they decide to come on board with the program, this can be very motivating for both the patient who's feeling empowered with this change, as well as for the family members seeing that there's something they can do. The client is seeing that they're making a change despite what they're going through. They're making a positive change now for their family members. We just within the last few weeks, one of our clients came on board to the program, and she's a woman in her late 60s with a stage 4 lung cancer. So she came onto a program and she's looking to make a change. She's getting some palliative treatment right now. So she's come on board. But with her comes her 3 daughters. who are all smokers and are using tobacco and wanting to make a change and wanting to quit. And they are motivated, of course, by their mother, who is newly diagnosed with lung cancer. So here on board to this program, we now have the client. We have her 3 daughters who are in their 40s, they are now making a change. And then on top of that, they bring the 20-year-old grandson who's looking to make a change, has been using tobacco for the last 3 to 4 years, but now is motivated by grandma to make a change. So I really like to see this. I see them all supporting each other, and everyone is getting their own sort of benefit from it. The patient is feeling that despite her diagnosis, she is making a change for the rest of the family in a positive way. The family members, although they might feel a little bit helpless that they can't help the patient and make changes, in the way she's feeling, they're feeling good to make the change for the rest of the family as well for themselves. And then, of course, the next generation, the grandson, making the change. When a family does it together, of course, it helps with changing the behaviors. So, of course, we look at cessation and the addiction to the nicotine as well as the behavioral component. Having the family on board really helps with the behaviors and the behaviors at home. Once we have everybody sort of engaged, we can make better changes in their routine, changes in where they're smoking, where they're not smoking. People are more, when they do this together as a family, they're more able to, come back and say, I heard what you said, we've changed our kitchen seating area. So I sit on the other side of the table and we've moved the table, and it's helped me not want to sit down and have that cigarette right after supper. Now I get up and do something different right after. And so it's those kinds of things. As long as everyone's sort of engaged in the family, it's really helpful to making a change in the behavior. We help patients through a team approach. Our team consists of a primary clinical nurse who's really engaged with every patient. So, this person is seeing every single patient right from the start. We see the patients initially in clinic as a new patient. We see every patient as a new patient, provide information, and then depending on where they're at and where their readiness is, we go from there. The clinic nurse is just involved with every single patient. I'm involved in the program as a nurse practitioner right now, and I do see every patient. I don't. The primary nurse often takes over to do a lot of the follow-up. Certainly I would do the assessment and prescribing. We have a pharmacist or a group of pharmacists involved in the clinic, and we write the prescriptions here and send them up to our pharmacy who provides the medications. We have nicotine replacement, Zyban and Chantix available for medication-wise. So the pharmacists prepare those medications and bring them down to meet with the patient and go over their use. We have a social worker involved in the program who does meet with patients, especially those who may need further support. We, being in the situation they're in, often patients have a lot of emotional needs and supports that's needed. But we do have a fair amount of patients who are schizophrenic or have other challenges that we need further support for these patients, and the social worker is helpful. We also have a data manager who's involved with our numbers and pulling the data. So again, it's a personalized program, individual assessment. We like to keep that as key, especially if we're doing things like prescribing. We want to really be involved in what the patient is on and what they're doing. If they're on, there's certain medications that have a lot of interactions. Zyban, we find it can be limiting depending on what patients are on. For example, tamoxifen shouldn't be used with Zyban. There's certain interactions, so we really keep this as individual assessment. So even the the client that came in with the three daughters, we might see them together to start, but then we take them each and see them individually so that we're having a plan that's specific for them, that's going to work well for them. We provide counseling. Counseling is provided by us in the clinic, by nursing, as well as by social work. These clients are needing ongoing support. If we're starting medications on a client, then we want to be talking to them the next week to make sure they're doing all right, and then we'll see them either 2 or 4 weeks later. We like to provide a lot of phone call follow-up at least once a week to provide support and encouragement for the patient, and to look at side effects of medications. Again, the three sort of groups of medications are provided at no cost to the client. So, and they're done through our inpatient pharmacy here, given as outpatient prescriptions. We also use a CO monitor in the clinic. A lot of our clients find that motivating to look at their number and see their number going down as they're tapering down or as they're quitting. So our results, we've had all clients, family members, and staff access the program. As I've said before, the clients have found the resource to be empowering in a situation where they're told they have a diagnosis. They're, we talk about treatment and involve them in the treatment process, but really it's very prescriptive. This is one program here where our clients are reaching out to us, and they feel that sense of control. They're reaching out, they're saying they want to make a change, and they find that it is a good time for them to making a change. Again, the family members feel empowered and feel that they have a role as well with their family member. So with Manitoba, we have a large area, and we have clients throughout the province. So what we do is if clients are in for treatments locally, then we will see them in clinic. If they, say, came for their first visit here, their first oncology visit, but are receiving the rest of their chemotherapy in Thompson, then we will see the client through telehealth to start. So we'll start with telehealth, assess them that way. We can get the drug if they're wanting a drug to use. We can get it sent out to them, and then we will follow up by both phone call as well as telehealth. And then, of course, we like to see them in person when they're in. So when they do come in for their oncology visit, we try and coordinate so that we can say hello in person and see how things are going. We also have smaller oncology centers in Winnipeg. So these are CancerCare Manitoba. We have a large site here at the McCharles site that is attached to the Health Sciences Center. We then have another site at St. Boniface Hospital, but then we have more community hospitals like Victoria Hospital, Grace Hospital, and Seven Oaks that are smaller oncology centers. They don't have an oncologist. They have family physicians in oncology or nurse practitioners in oncology that are supervising patients, although some of them are opening up now to have oncologists on hand and doing clinic out that way. But we are trying to connect with them and make sure that they are aware that the program is available and patients or clients can be seen. One of the issues is their treatments are often not at our site, so our program is only at this site, at the McCharles site. And so one of the issues is similar to how patients were speaking to us from the start, where I'm not sure I want to make another clinic appointment when I'm, having my chemotherapy weekly over here. So we're trying to connect with them. We are using telehealth and things like that, and trying to do some of the follow-ups by phone to make it convenient. So another area that we are trying to reach out a little bit more in is the inpatient setting. So our cancer care is only outpatient. Our oncology patients are sort of spread throughout the hospitals, and there is no specific oncology ward in the hospital aside from the blood and bone marrow transplant ward. Otherwise, our oncology patients are sort of spread throughout the hospital when they are inpatients. So, and often they're being diagnosed with a surgical intervention with being a hospital admission. Now, the Winnipeg Regional Health Sciences Center are starting to develop a program and really being active as treating patients in hospital for nicotine withdrawal. And so many patients are not using tobacco when they are inpatients. And what we are trying to do is really collaborate with the Health Sciences Center, and for our oncology patients, taking them on is we're wanting to take them on as clients once they're discharged, because often it may be that 2 or 3 week lag there where patients or clients start to smoke again when they're waiting for their outpatient oncology visit. So we're really trying to capture them and work closely with Health Sciences Center to capture those patients before they're discharged. And again, this just goes on to say that the tobacco use is not allowed on hospital property. Cessation is encouraged. A lot of NRT is being used in the hospitals when appropriate, as well as other medications. And we are just trying to capture those patients before they go home. Too often we're hearing that they started back smoking just in the past week or two when they've been at home. So CancerCare Manitoba cessation program data. So this is the data from January 2012 to August 2014. So we're right now into October, we're a little over 300 patients that have accessed the program. As you can see, we have a variety that are using the program. The clients themselves are the largest group, but family is right behind, and then a small proportion of staff. So, and this is some of our outcomes when we were starting to look at it. When we look at it overall, we're with both the quit and the reduced, as well as supporting clients who have made the change already, we've made a sort of positive impact on almost half the clients that we see. Because we've been in place for so long now, we've had some people that have relapsed on the program, and a very small amount that have increased. But this light blue area where it's unknown, is one area that we're trying to work out and sort out the data from that and just see where these clients are at. We find that some of these clients may be deceased. We also know that some of them are quit and don't want to be involved with the program anymore, and some of them likely have gone back to using tobacco. So we're trying to sort out that status so that we don't have such a large unknown here. So the number of participants who quit. Now this is a tricky slide because we're looking at just one point in time. Of course, we're not looking at each individual and how long it took or anything like that. But you know, when we capture this in August, this is sort of the numbers that we found, that there's been a good percentage of patients who have been quit for a significant amount of time on the program. And the time to quit, I sort of like to use this slide because we know that when clients are coming on to the program or approaching you about wanting some information about cessation, they are not necessarily ready at that time. And we encourage those patients or those clients to come and see us just to talk, because often they haven't heard the rationale for quitting. they are, undecided. Do you think it's worth it? Kind of questions we get, and how could you help me or others? So often we see clients and right from the start, and then we like to work with them and see where they're at and with their motivation, with their readiness, with their confidence, and try to get those numbers up and get them ready to make a quit attempt rather than jumping in and they're not sure they're ready for that change. So what we find is that on average, it takes approximately 60 days from that first visit to when they're quit. And I find that helps client, and we didn't look at that specifically and say it has to be at that point. But what we've found is that clients are more prepared to make a change. They're watching how they're smoking. They're watching the reasoning for smoking, if it's cravings or if it's their behavior, and they're sort of working themselves up for that quit attempt. We've looked a little bit at our data, and we found that we use nicotine replacement the most. We have a lot of clients that feel that that have a preference when they first come in. There has been some recent information about Champix that had recently come out, and I know that skewed things a little bit, where clients are more prepared to use nicotine replacement initially rather than anything else. And I think that reflects in our data here. The medication only would be either Champix or Zyban, and both NRT and medication, that would be only for Zyban and NRT. There are some clients who choose to use no medications and simply want support and motivation to work with us to make that change. They want some feedback from us on how to make the change, and we work with them closely. So not every client has to be on a medication. We're also developing almost completely developed guidelines for smoking cessation. So the first phase of our guideline, which is in draft form, but we're actually looking for reviewers. So if there's anyone who's in oncology and would like to be a reviewer, we're looking for to finalize these guidelines in tobacco cessation with oncology patients. And so this first phase is just looking at cessation with oncology patients and giving the literature and background on why we're doing it. We're looking at each of the treatment modalities and how tobacco use impacts these modalities. So those are near completion. The second phase is to look at the type of cessation treatment in the oncology setting. We don't have a whole lot of literature on that, but we're trying to pull what we can to develop the most concise information that we can. We're also working in collaboration with the University of Manitoba with the Faculty of Nursing. We've been working with students in the fourth year course for health promotion, and we've worked with them over the last couple of years, and they've helped to develop clinical tools that we use regularly. So one booklet that we use with every single patient that we see, some information on the CO monitor, and they've really played a big role in this when we're sort of all doing off the extra projects and cessation off the side of our desk. They've really helped out with that to help us along. So this is just one of the examples of the students' work for smoking cessation, and this is a booklet for cancer patients. It has a lot of great information, literature, information about withdrawal, information on why patients or clients should quit, and information about the different treatment options if they decide to use. So next steps, of course, we're always looking at funding and staffing allocation. So to start, we started with some support from the Cancer Foundation, CancerCare Manitoba Foundation, and we're looking at securing financial funding for ongoing support for our clinic, looking at staffing allocation. Of course, when things are tight in the clinics, we tend to get pulled to support the oncology clinics, and cessation is often left lean when on those times. So we're looking at more staffing allocation. We're finalizing our clinical practice guidelines, and we want to continue to collaborate with the other centers. All right, so just some acknowledgement to some of our partners here at CancerCare. Venetia Boyer, Jill Taylor Brown, Kristie Hoffer, and myself sort of started this program together with the initial request from Venetia and Jill, and we appreciate that. Valerie Reeve, who has been supportive all along, and primary nurses Marissa and Letitia have been excellent for ongoing support for our clients. Thanks very much.
Okay, everyone, Tanya here again from the Teach Project. If you have any questions for Kristie, please feel free to ask away. You can either type into the chat box via web, or you can push *1 on your telephone line to unmute your line to speak. I noticed, Kristie, that there are a couple questions in the chat box regarding the resource and booklets that you had mentioned during the presentation.
That's interesting. Actually, we certainly would be happy to share. If you want to share your information, I'd be happy to send you out some samples to look at. I think they're really great, and like I said, we use them with every one of our patients. We did get a little bit of client feedback when we first started with them, just to see what format and what information they were wanting. So I think we have a great booklet that we use, but we're happy to send out and share if you'd like, for sure.
Okay, great. So I guess if anyone is interested in those resources, then email us at teach by, let's say, the end of this week, and I can put together a list and send that off to Kristie. Okay, so Kristie, if you go to the chat box and scroll up, there are quite a few questions posted here. So I guess the first question there is from Rita.
We've had a couple of different social workers in the program, and they really make it their own as to how they're involved in the program. Right now, we have someone who's very motivated and works really through the entire process. So not only looking at our guideline development and being an active member there, but also with the clinical work. So where we would see the clients initially through nursing, the clients are then referred to social work, and so they're there to provide extra support for the patient, motivation, and certainly they're more of an expert in the motivational interviewing and that sort of thing, and they can really work well with the patient, and they collaborate well with us as well. Initially, we had some of the patients coming on an intake through social work, and again, this was when we started with different providers, but we found that some clients were missing having the opportunity to use medications where they might have found it helpful. So that's why we have them right now entering with nursing, so the medications can be provided, and then the further support either through us in our part of the clinic or with the help of social work as well.
Okay, great. The next question here is from Dawn. What do you do
Smokeless tobacco.
What do you address for those who use smokeless tobacco?
For chew and things like that? Is that what that question would be? My guess would be. And if it is that, we really look at it in the same way. So we look at it the two sides. So the addiction part of it and the behavior. So it's looking at really having the client look at their behaviors when they're using it, why they're using it, and how much, and then looking at substituting when we're looking at the addiction part of it, other, say, nicotine replacement if required to help them get through the cravings and changing the behavior of it. So we're really looking at it in a similar way to what we do for smoking cessation. Right. So we've looked at this with our clients. One of the things that we always look at, and it's similar to patients who have recently had strokes and that kind of thing, is that you're looking at are these clients going to continue to smoke? And if they are, they're being exposed to it anyways, right? So one of the things that we look at is what product are we going to use for cessation if nicotine replacement seems to be what is going to work best with the client. Then what we do is we want them to use it and we want them to taper down and off of it, right? So if they continue to smoke, it's not going to change their nicotine intake. They're going to be taking it in. They're not going to make a change. Substituting the nicotine replacement for the smoking takes away the harmful effects of the circulating smoke, and then we're able to taper off and come down off of the nicotine replacement. Okay, so the CO monitor, actually some of our clients have said it looks like a breathalyzer, and it sort of does. So it's a machine that we have. It's handheld. Sorry, I don't have it here. It's handheld. It has a disposable mouthpiece, and the client blows into it. When they blow into it, it measures their carbon monoxide levels. And we keep note of that number. The client keeps note of that number. And many of the clients see this as very motivating, especially if they're looking at reducing to quit. So they're cutting back the amount that they're smoking and then coming off cigarettes. Or people say who are using Champex and are smoking during the first couple of weeks and then quit. These people find this number very motivating because it can be quite significant if they're smoking a package or so a day. And then once they're coming down, they see this number coming down, and it's working well for them. Certainly, we have some clients who do not want to use it. It's the kind of client who feels as though we're checking up on them or something like that, and that's fine. We don't need to use it. We don't have to use it for every client, but we do use it as sort of a motivating tool for them. So overall, for the e-cigarette, we advise patients or clients not to use them. I just feel that we don't have enough information on them, and I think I share that with probably a whole lot of people across Canada, that we just don't have the information on them and certainly the long-term effects of them. The other aspect to that is clients can be using them with nicotine, so it's they're still taking in the nicotine. Then there's the aspect of the flavors, right? If it's coming in bubble gum and grape, who are they targeting? We certainly have a high rate of youth smokers or youth that use tobacco products. So we don't need to sort of engage anymore in the behavior either. You could also question if there's some effects of secondhand vapor, right? Or what are the effects of that when people are using them indoors? So overall, I tell people that we just don't have enough information. I encourage them not to start to use them if they haven't, and if they are wanting to use nicotine replacement, we look at using the products that have already been tested and to use them and then eventually get off of them.
I had a question from Richard. What percentage?
Yeah, I don't have that information in front of me, but I would say the majority have had at least one or two previous attempts. Now, when we're looking at clients, who are say 50 years old, often it was with the birth of one of their children or something around there where they've had one or two attempts. We've had some that have had many attempts, and they present themselves to us and say, well, I don't know what you're going to do with me. I've tried already. Good luck. We do have those clients. But also we do have clients that come in, they have a diagnosis of cancer. They may be 65 or 70 years old and have never made a quit attempt or made a change since they started smoking when they were 15. So we definitely have sort of the full gamut when we're seeing clients here.
Question from Brent. You mentioned that patients are provided cessation medications.
Yes.
Do you provide medications for family
members? Yeah, so what we do is we see all patients as a client of the program. So when we have family members, they come in as a client on the program. They're set up with a chart. We do a full health history. We pull their drug history. So if I guess it's me, if I'm prescribing for a patient, I want to know that, so their background and what they're on and what potential interactions there could be. So we're making a chart, and this is now our client. So although they're a family member, they're our client now in the program. Because we need to collaborate. If they have a psych health history and that kind of thing, we're collaborating with their psychiatrists or with their family physicians. Notes from the visit when they see me go to their family physician or practitioner or psychiatrist or whatever it may be. So we are seeing these family members as a client in our program.
So next question is from Tanya. Oh, I just lost it. Oh, there it is. What other resources for cessation do you use?
Right now, we don't use e-cigarette, and as I said, I don't encourage clients to use the e-cigarette at this time just because I don't feel we have enough information or certainly long-term information on it. We don't have acupuncture or hypnosis in our program. We don't have a lot of information on it, but one of the things that's shown is if the client thinks that it will benefit or they have benefited from it before, that it should be used again. So although we don't have it in our program, we certainly encourage them to use that if that's what they're interested in, but we don't have it to offer through the program.
Okay, we'll take one final question. Any other questions we will gather and I will send them off to Kristie following the webinar, and we'll provide answers for those probably within a couple of weeks. So final question. How does NRT
right, so
treatment
The
options
further
affect
radiation treatment, we don't have a lot of information on how the drugs impact it. Again, we do know that the circulating smoke can have an impact, and the changes in the oxygenation of the cells have an impact on the radiation treatment. So we do have that information. So we know that smoking isn't great on radiation treatment. Nicotine replacement is a better option, and we're also able to taper that off and come off of it, as I mentioned before. So we also think of that when patients have had a stroke or something like that. If the patient's continuing to smoke, they're continuing to be at risk. If they're using on NRT, we want to use it, but use it as quickly that we can taper them off of it, that they're not going back to smoking, because it is a better option than using cigarettes and smoking.
Okay, great. Thank you, Kristie. So if you have questions for Kristie still, please continue to type them into the chat box. Alternatively, you can email us at teach@camh.ca, and I will send all those questions to Kristie following today's webinar. So remember, a link to the evaluation and post-learning assessment 2 will be sent out by email by tomorrow. Both the learning assessment is required in order to receive your letter of completion. So if you've attended today's session in a group, or if you have joined via teleconference only, please be sure to email us at Teach or me personally with a list of your name and email address by end of today. Our next Lunch and Learn session will be on Wednesday, November 5th, so coming up very soon in 2 weeks. Registrations are currently open, and the topic is Pregnance, a Tool on Quitting Smoking and Pregnancy, with Nadia Minion and Jessica Penner. So thank you everyone for joining us for today's session. I hope you enjoyed it, and we'll be sending out the post-webinar
Thank you very much.
by tomorrow.
Bye.
Thank you again. Thank you, Kristie.